Well, hello and happy Monday, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, of course, with the Chief Medical Officer of the Centeno-Schultz Clinic, Dr. Chris Centeno. Dr. Centeno, good afternoon to you.
Good afternoon, Jason.
Hopefully everybody had a great weekend. Lots going on. We've been having some terrific conversations about what you can do to take back your power and learn more about your orthopedic conditions. Any pain you might be experiencing in your joints, the joints of your body, from your head down to your toes, all in between. Where bones are together causing pain and problems, we might have a solution for you. Specifically today, what we're talking about, our conversation for today, is the PICL procedure, a very specific procedure that I believe you are the inventor of. Let's get into how it's evolved over the years. People have had it over the years, and now it continues to improve and grow. Let's get into what the PICL procedure is and what it's like now, different than it has been in the past.
Yeah, so first, PICL procedure was invented by myself to address craniocervical instability. So that means the ligaments that hold the head on are loose. So that's called CCI. And those patients generally either have been in some sort of trauma, let's say a rear end car crash or something hit their head or they landed on their head. We see a lot of sports injuries, for instance, where people land on their heads, or they were just born with loose ligaments. And because they've got loose ligaments, they end up getting loose ligaments up here where their head is connected to their spine. And that's also called CCJ instability, craniocervical junction instability, CCI, craniocervical instability, AAI, atlanoaxial instability if it's C1, C2. Now, the most common treatment for those patients generally was screw fixation. So what that means is that someone would go up here and fuse this area and put in big hardware, or they'd put a screw through the C1, C2 joint. The problem with that approach is that it's pretty invasive. So, for example, if you operate on 100 patients with that kind of problem and you use these fusion techniques, you're going to have pretty serious complications in 10 or 20. And if you operate enough patients, you'll eventually see a patient death related to the procedure, meaning that these are higher risk procedures than regular cervical fusions. So we developed the PICL procedure, which is a procedure where we can directly inject those ligaments that hold the head on. That comes from the front, so we use an endoscope to see where we're going. We then use X-ray guidance to place those cells, in this case, the patient's own bone marrow stem cells, directly into the ligaments. And the goal is to get those ligaments to heal and to reduce the craniocervical instability.
I'm going to see if I can break this down into very simple English and language from medical anatomical physiology into the basics. And that is the cranium is your skull, and the atlantoaxial, meaning the atlas is the first vertebra of your bone, the axis is the second vertebra of your bone. They sort of work together differently than the rest of the spine because of the way they're shaped. They're responsible for most of the rotation of you moving. So if you turn left and turn right and find you can go significantly farther to one side versus the other, that gives you just an indication of the movement, motion, or flexibility, freedom of that joint. Ligament laxity, ligaments hold the bones basically together, so they work together. Laxity means looseness. So if the ligaments are loose, that means there's too much motion or movement. Now, why is that a problem? Well, at the top where your brain sits in your skull, it exits out the big hole. They literally call it the foramen magnum. And the brain turns into your spinal cord. It's really one tissue that extends. We give it different names because of where it's placed, but it's your brain. And your brain is responsible for most of, if not all of the functions of your body directly and indirectly, and that is going through your spine. And so help people understand when that ligament laxity happens, Why is that such an important part of their health, their physiology, and the wide-ranging number of symptoms it can cause just from that one area, being kind of where that's located?
Yeah, so realize that lots of stuff comes through this area. So as you said, your brain then goes to your brain stem, which then goes to your upper spinal cord. That goes through this area. Then you've got lots of other nerves, the vagus nerve and other cranial nerves that go to your face and head that go through this area as well. So if this area is unstable, any of those can get irritated. That can lead to kind of crazy symptoms of numbness and tingling, for instance, in an arm or a leg. You might get rapid heart rate if it's the vagus nerve. The occipital nerves are back here, so that can cause headache. The upper cervical facet joints also can cause headache, and they can become arthritic because of this extra motion. So if your head is not held on tightly by these ligaments, obviously that can be a problem. So the goal of the procedure is to try to tighten down the ligaments without those huge surgeries.
That is an essential part to understand, is the stability of that area is the goal. And I guess then it becomes, and I just want people to understand kind of what the goal is, because if you've got the ability to do a needle injection that will tighten the ligaments versus a screw in the bones that will be there permanently, so long as you don't actually break it or do something that causes more damage, it would seem relatively easy to make the choice between the simple one that actually fixes the problem and the really invasive, dangerous one that doesn't really fix it. It actually causes a whole host of new problems. Because you can think of a situation like this: if you have a bicycle chain, you know that in order for your bicycle to work right, it has to have movement or motion, it has to be lubricated. One of the worst things you would do would be to sort of tape, glue, or weld the chain together and expect for that chain to work right. Yes, you could say, well, that chain's not going to break there because you've reinforced it, but anybody with some logic would know you're going to actually break it somewhere else much faster because of the additional tension and stress caused by fixing those two bones. Does that all sound right, Doc? And I just want to make sure everybody sort of sees the easy solution to this would be to have the injection. I guess my next question for you is, how does somebody get an accurate diagnosis if they have this type of instability?
Yeah, that can sometimes be an issue. Sometimes these patients are like pinballs in a pinball machine, going from specialist to specialist to specialist. Cervical MRI can help, but it's static, meaning it doesn't move. And we're talking about a movement-based concept, which is instability. Movement-based MRI is even better. So that's usually a sit-down or stand-up type unit. And then we can also look in real time using X-ray at how these bones are moving to see if the ligaments are loose. And that's a technology called DMX, or digital motion X-ray. There's also a CT scan technique that you can use as you turn the head, looking at C1, C2. So lots of different ways to get to the diagnosis, but more often than not, patients get to physicians that don't really know about CCI, and a lot of these problems get ascribed other causes. So as I said, we did that PICL procedure. We've been doing it now for about 5 years. I'm the one that pioneered it. I did the first probably 150 cases or so before any other physicians at our office attempted it. And we've made some progress through the years.
That is fantastic. Let's get to some questions, and we'll keep on rocking. Our friend Rachel says hello. Hi, Rachel. Thanks for watching. And then she goes on to comment, looking forward to this. And we're happy to have you, Rachel. Thank you for joining us. We have this one submitted in advance by Charlotte Lansing. She says, there are so many patients with this issue here in England. Do you treat international patients? How do people around the world get access to your care, Doc?
Yeah, we do treat international patients. In fact, a good number of our patients are international. So for instance, last week, I think we saw 2 Europeans in the clinic. So that's pretty common. Usually they'll come over. They'll obviously spend more time, maybe a week here, rather than just the couple days that the average US person would. But before we go on to other questions, I want to get to that main issue or that main topic of how has this thing changed through the years. So when we first started this procedure, we used an off-the-shelf little plastic thing that we found that sort of kept the tongue down and allowed us to see the area. At first, we actually just used direct visualization with a light to clean off the back of the throat. Then it advanced to using an endoscope where we could see it more clearly, the back of the throat area. Then it advanced to starting to create custom 3D printed mouthpieces. Those are probably in their third or fourth iteration right now. We have multiple different models that we use. Some work better in some patients because of their anatomy, others in other patients. And then more recently, not only injecting below the atlas, but we've also started to inject above the atlas to get directly more into the lateral fibers of the alar ligament. So this is a procedure that, for instance, if you had it 5 years ago, it's dramatically different. If you had it even 2 years ago, it's fairly different from what it was 2 years ago. And, finally moving into that place where, we've seen 95% of all the different variations we're going to see. And we're at about approaching 300 procedures now. So that's the good news.
Right on. All right, we got a bunch of questions coming on in, so I'm going to speed up here a little bit. Our friend Doug Smith asked the question. I'm going to try to read it as best I can here. How does a PRP stem cell know a ligament is lax and needs tightening up?
Yeah, it's a good question. It doesn't really know that it's lax. So if we inject this stuff into a ligament, what happens? The first thing that happens is a fairly substantial inflammatory response because ligaments normally don't have bone marrow cells in them. And that's that inflammatory response that really kicks off a healing response. And so we've then put cells on the ground that can help orchestrate, i.e. the stem cells, that healing response. And then at the end of the day, turn into ligament cells if needed. So it doesn't really know it's lax, other than if you inject something like this into a ligament, it creates a pretty substantial inflammatory response to kick that off.
Very cool. All right, so I've got Daniel, who appears to be, I think, a spokesperson for the people in the CCI PICL patient Facebook group. And he says, good afternoon, Dr. Centeno. A number of us are members of the CCI patient group. Thank you for having the call. It's a great opportunity for us to ask questions. He has 5. So I'm going to start with the first one. You might have just answered it, but I'll ask it anyway. Number 1, the procedure has evolved over the year. What are some of the most recent refinements?
Yeah, so probably the biggest one, Dan, is an improvement overall in the mouthpieces, a further refinement of the anesthesia as we've gone on, because it can be very difficult anesthesia to do. And then the third, as I said, is starting to go probably about 2 years ago. We started to experiment with going not only under the atlas, but over the atlas. And by going over the atlas, we can reach some of the higher ligaments, but also we can reach the top part of the alar. So if you inject the alar accessory complex, they're really the same ligament. From the bottom, it tends to go up like that. But then there's a top sling portion of the alar ligament that we can now get directly. And, much of the last year has been spent dialing in how do you do the above the atlas, not the dens, injection, and how do you perfect it? Where are the appropriate injection points to maximize spread into that upper sling portion of the ligament? So again, just learning more and more as we go, but finally getting really confident in that above the atlas type approach.
And you do think about this the way a scientist would. So that leads us to question number 2. We know the clinical trial has not yet concluded, but can you share with us some tidbits or some general results that you tend to see in your patients, even if somewhat anecdotal?
Yeah, so the clinical trial that Dan's talking about is a randomized controlled trial. It's no cost. We actually suspended it for about 6 months, largely because, and this has happened not only with this clinical trial, but it tends to happen with all clinical trials in a clinic that treats patients. We were having patients bleed into the study that really shouldn't have been in the study, meaning that they didn't really fit the inclusion exclusion criteria. So we had to kind of stop it for about 6 months, think about who we wanted in this study, who we didn't want in this study, and it just restarted a few months ago. So there's only a few more patients that have been put in. But so far, again, I think the study patients that we have, including the patients that we treat, generally show that this can be a game changer for most patients that do this procedure. So nowhere near 100% success rate, but we're seeing success rates of 70 to 80% in patients that are otherwise almost impossible to treat without that fusion surgery. So that's generally what we're seeing.
Okay. Number three, are you able to inject the longitudinal bands of the cruciate ligament, i.e., the vertical superior and inferior bands that connects from the odontoid to foramen magnum and C2 body?
Yeah, so you're really talking there about what's been called the apical dens ligament, but as it extends inferior, it would be called I guess the vertical portion of the cruciform. So, cruciform in Latin means cross. And so the lateral portion of that cruciform ligament would be the transverse ligament. The vertical portion, I think we've just described. So the answer is yes. If we need to get to it, we can inject it from above. That's what the above the atlas approach allows us to get to if we need to. And then as far as getting it going down, that would be easier for us to do as we inject the transverse. It's going to get a portion of that. The inferior most portion is still going to be a little bit tough to get simply because realize we're coming in from either side of the dens through that C1, C2 hiatus. So being able to make a sharp left or right turn might prove to be difficult to get that lower portion, but the upper portion much easier to get now that we're
Right.
doing this new procedure.
Questions keep coming. Number four, a number of us patients have injured and stretched CO-C1 joint capsules. Are you able to inject the CO-C1 capsule itself to tighten it as opposed to injecting the BMC inside the joint itself? How can the CO-C1 and C1-C2 joint capsules be tightened?
Yeah, so that's not that hard to do. Basically, we can get both of those joints from the back, which is the way they're normally injected. We can obviously go intra-articular and then inject as we pull out into the capsule. Now, both of those joints, again, if there's a need to, can be injected from the front. And in fact, we'll inadvertently get into the C1, C2 joint sometimes when we're going through that little opening or the hiatus between C1 and C2 from the front. So that would be the same thing, injected intra-articular and then pull back as you get into the capsule. And then again, C0, C1 now can be accessed from the front as we're going above the atlas. So that's it. So we could get both the front and the back of those joint capsules if that were something that's a priority on the list.
All right, we got more keep coming. So let's go to number five. Number of us with craniocervical instability due to an injury also have significant persistent C2 rotation that despite many treatments doesn't budge. Often that rotation is very rigid rather than too lax. What in your view causes that rotation? Is it scarring or shortening of RCP major or other causes?
Yeah, so what I think Dan is talking about there is that there are not only the ligaments that we're discussing, but also muscles that connect in to the back part of C1 and C2. Those muscles obviously have a fairly large pull one way or the other, and they go left and right. So it's certainly possible there could be some scarring in the muscle itself. If that was a thought, then we could try to hydrodissect around the muscle tendon, and or tighten down the opposite tendon would be one way to try to address that if it's due to the posterior muscles.
All right. Lots of reasons, lots of causes. Great questions, Dan. Thank you. Let's keep going. Rachel asked the same question. I think, again, you've answered this. How have you refined the PICL
Yeah.
procedure over the years? We've addressed it. Rachel, I'm sure you've got that. Thank you for that. Nate here is asking Rachel a question. We'll skip that. Here's Rachel's next question. Which one is easier to access, the transverse or the alar?
Yeah, so the accessory alar, just so that you understand it, we give these ligaments individual names, but they're kind of all connected once you get up there and inject them. So the accessory goes up into the lower alar. So that's probably the easiest for us to get to. Transverse ligament has taken us probably 2-3 years to be able to dial in. And so the transverse ligament comes across there, but it kind of attaches to either side of the atlas. So we now know where those points are. So that would be the second most difficult one, but one that we're routinely getting into now. We didn't when we first started doing this many years ago. And then, the hardest one is probably just the newest one, which is going above the atlas and getting the sling portion of the alar ligament. Realize the body is full of slings. And what I mean by that is a sling tends to kind of suspend something. So in this case, that upper portion of the alar ligament is suspending the dens. So that one, probably the newest one, being a little harder to get to, but we've dialed it in for the most part to date.
That's fantastic. And the improvements keep coming. We've got Kelsey's got a question. She asks, which symptoms are most likely to improve, pain or neurological?
Yeah, so we generally see both improve. So the first most common symptom of everyone with CCI would be headache. So that's one that generally improves. Now, sometimes we have to dial that in a little bit to try to find out where it's coming from, because sometimes, there's 3 or 4 things on the list that could be causing that. So we've had to go back and treat the headache more aggressively. Then you've got, sort of imbalance type symptoms. Those would be the second most common thing to improve. Then the third thing would be neurologic symptoms, all the crazy stuff, my leg goes numb, my heart races, which can be vagus nerve, other types of things. And then probably the toughest nut to crack so far has been some of the more facial pain type stuff. That one, we're still working on. It's kind of hit or miss right now, but we're still working on the overall concept of how to address that.
Excellent. Kelsey's follow-up question is, how does instability cause occipital nerve compression or entrapment? Does PICL address the head and facial nerves, or is that the nerve hydrodissection procedure?
Yeah, so realize that these are nerves that come through the back part here of the head. And so if you've got instability, those nerves are snaking their way through muscles and tendons, all of those same muscles that Dan was talking about before. So if you've got instability from a ligament standpoint, those muscles go into overdrive, the nerve gets compressed or irritated. So the first component of treating that is obviously getting rid of the instability or trying to help that. The second component might be treating the nerve directly, which is that hydrodissection part that you just mentioned.
There we go. That is, those are our questions for right now, Doc. I guess as we wrap up today's show, help people understand, this is not an easy thing to find a diagnosis for necessarily. There's a lot of people that have the condition and have an inaccurate diagnosis. There are a lot of different symptoms, syndromes that could be caused by problems up here in the neck. Help people understand why you and this is such a unique procedure and so important to find out if you are suffering from this, because they're really, I guess, what are the bad decisions people make if they don't get an accurate diagnosis or if they don't go this approach? What are the negative consequences of sort of following the mainstream or staying in the dark, I guess, is the best way not to ask it.
Yeah, listen, this is a tough area because you've either got someone gets better with highly specific chiropractic care, which would be AO technique or NUCA, um, or it gets kind of better on its own, or someone ends up with a big surgery. Now, the big surgeries can include the fusions. We've also seen people get Chiari decompressions, which is basically carving a hole in the back of the skull at the top here. And so I think the biggest problem that we see with this is patients who get the surgeries, they're no better. Maybe this is better, but now that's worse. And those are some of the most difficult patients we see. We can help a few of them, but far fewer than if we had seen them before the procedure. So those patients are usually, beyond the point of no return. So if they get the surgery and the surgery doesn't work, or it solves X but makes Y much worse, those patients have a real tough run of it. As an example, many times screws are placed to the C1, C2 joint. If the C1, C2 joint doesn't fuse, that's a problem. If the screw gets placed too far into the C0, C1 joint, we've seen several of those, then that joint gets destroyed. We've seen, occipital nerve sacrifices, which are common with some of these posterior screw techniques. So then the occipital nerve is permanently damaged and the person's got permanently worse headaches. So that's the biggest thing, is trying to convince people that you can always do the surgery. There's nothing about anything we're doing that's going to change your ability to do the surgery. But you can't go backwards. Once you do the surgery, there is no turning that bus around. So that's probably the most difficult thing we see.
I'm going to do Daniel a solid here. He got in just in time, and I know he's got a lot of people with him in the group. He just has one last question. It says, do you use specific BMC dosage for each specific CCJ ligament treatment? And do you always use all the collected BMC?
Yeah, so Dan, when it comes to bone marrow concentrate, realize what we're using is highly concentrated. So for example, just to give you an idea of concentration factor, we'll generally take 90 cc's of bone marrow, and that's going to go down to about 3 cc's of injectate. So that gives you some idea of the concentration factor, 90 to 3. So when it comes to bone marrow concentrate that's just out there, normally it's not that concentrated. But for a cervical procedure these days, we'll generally use all or most of the bone marrow concentrate. Sometimes we'll have some left over depending on the size of the patient and how easy or difficult it all is, and where else we're using the bone marrow concentrate in the neck. But generally these days we'll use most of it or all of it in the cervical spine. Maybe about 1 in 3 times we'll have some left over to park someplace else, or can take a little bit more on the front end to try to have some left over if there's other things that need to be treated.
Right on. And do you have a moment for one more question from our buddy Tom Walsh?
Sure.
All right, let's bring it on. Tom says, hi guys. I met with a surgeon today who recommended a cervical fusion as a treatment for my radiculopathy. Why is it when I mention orthobiologics as a treatment, they all reply with the same answer? Quote, there's no data available to prove that orthobiologics work. Show me the data. End quote. Where can I show them the data?
Yeah, a good place to start, Tom, would be on the website. The studies as are published get put there on the regenix.com website, also the Centeno-Schultz blog. But, that's a little bit of a ridiculous statement because we don't have any level 1 data that cervical fusions are effective. So that's the standard we all use in medicine is level 1s. That's a randomized controlled trial against either a common comparator treatment. In this case, it would be physical therapy, or a placebo treatment, in which case that would be a fake surgery. So we have no data on that for lumbar fusion. The few studies that have been done that come close to that show that lumbar fusion is not more effective than no fusion. So that's a little bit of what my mama used to call the pot calling the kettle black. That statement comes from the time where you used to use open flame to cook, and both the pot and the kettle were black. It's a little bit ridiculous. So as an example, right now, just to give you a sense on PRP alone, we have about 40 randomized controlled trial. That's 40 Now, when it comes to cervical fusion, we have about one that I can think of. So you've got 40 over here for PRP and one for cervical fusion. So I would suggest that your surgeon doesn't know which end is up when it comes to orthobiologics. If I asked him to show me the randomized controlled trials, he couldn't find them. So again, I think what we're hearing instead is, hey, my bread is buttered by fusion. My bread isn't buttered by all those orthobiologics. Hence, I'm going to request that you give me much more evidence for orthobiologics than exists for my fusion. Obviously, that makes no common sense, but that's the way they're doing it. And listen, that's why Regenexx has been able to get coverage for about 8 million, on about 8 million people. And we continue to add month over month new companies because the companies aren't having it. These large Fortune 500 companies are looking at the fusion and saying, we're not doing that if we don't have to. The results suck. And at the end of the day, it's a huge, expensive surgery that can go wrong. We'll pay for this other stuff to see if we can reduce those fusion rates. So the Fortune 500 companies that make these decisions have now started to push back against the surgeons as well.
Yeah, it's hypocrisy at its greatest. It's a perfect example. And I guess, Tom, you can also ask them for their data because they don't have any. It's just ironic and that simple, but and you're welcome. All right, let's wrap it up for today. Let's see, we got a couple things here. Rachel is saying, thank you for continuing to refine these complex procedures. We appreciate you guys. Thank you, Rachel. We appreciate you watching very much. Dan says, hey, thank you for answering the questions, inventing the procedure, and providing these treatments. So thank you very much for watching and for doing a great job in the group, helping everybody understand. And I think that's very much what it's all about. Tom says, thanks, guys. And of course, we say, thank you very much as well. Listen, that's why we do these programs, is so that you can hear from the inventor himself how these things work, what's improved, what's changed, what you now have access to, and how to try to make sense of a very difficult situation. The thing you do want to start having is a bit more skepticism. It's ironic, as was brought up earlier, how easy it is for traditional doctors to go, well, there's no science for that, and yet an overwhelming majority of the things they do doesn't have science behind it either. Oh, the irony. Ask them for it next time. When they tell you there's none for somewhere else, go ahead and ask them to let them show you the studies on what they're doing. You're going to have a tough time finding it.
And Jason, yeah, let me give you a specific sentence to ask. The sentence would be, can you send me the randomized controlled trials against placebo, i.e. a sham surgery that shows that your surgery is effective? That's the sentence you want to use. The answer for fusion is there isn't one. The answer for all spinal surgeries, every single one, is there isn't one. In fact, the closest you could come to that would be discectomy, which is the Weber study against physical therapy, which showed that the discectomy was not effective against physical therapy. There's one I can think of for cervical fusion with stenosis, which again showed that the surgery was not effective against physical therapy. But that's the question you want to ask. Show me the randomized controlled trial data against a fake procedure, meaning patients who got the procedure, patients who thought they got the procedure but really didn't. And let's look at that data, and you won't get anything back.
Because there isn't anything. As a chiropractor for more than 2 decades, it's always at this point hilarious when doctors say there's no data for what you guys do, and yet when I go, well, where's the data on what you do? The data actually shows roughly 15% of medical procedures have actual randomized control studies behind what they're actually doing. That's 1-5, not 5-0, 15%, and that's actually what the data says. Anyway, let's move on. Enough of the hypocrisy. What you want to know is that if you've got these types of conditions, you should be getting an accurate diagnosis. And as Dr. Centeno mentioned a moment ago, if you'd like to find out if you're one of the up to 8 million people that do have coverage through the Regenexx network, you want to make sure you go to regenexcoverage.com and you can find out if you have coverage, if you've got an employer who is smart enough to actually understand the real science behind what's going on and is putting their money where their mouth is. They're saying this is good for our people and good for our bottom line. And when it's good for both, it's a great thing. So if you'd like to find out if that's you, then you can go to regenxcoverage.com. That's our program. Those are our questions. We got one more thank you we'll throw in there because we appreciate the thank yous, Kelsey. Thank you for thanking us. Until Friday, we'll be back on the Regenx Facebook page. As you know, Dr. Centeno and I are here each week, Mondays and Fridays. Mondays here on the Centeno-Schultz page, Fridays on the Regenx page. Each and every week sharing with you how you can take back the power of your own healthcare decisions by understanding how the system works, asking great questions directly from Dr. Centeno himself, and having us give you some feedback and reminder that you are the one who has the power to make the right decisions. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. Thank you for joining us. Well, hopefully we'll see you Friday. Until then, please share this video with those people you think might benefit from it. Until next time, stay well, be kind.